Thank you for the introduction. I've been on 7 medical missions from India, Vietnam, China to Jordan. And so if you ever have an opportunity, I was on a cleft palate team with Operation Smile. So if you ever have an opportunity to go, it is an amazing medical mission. So today what we're going to do is we're going to talk about the Pediatric Airway, but our clinic up in the Mooresville area, we're working on positioning, so our physical therapist is going to speak about that, tongue tie or restrictions, feeding, as well as speech. So we do work with pediatrics all the way, 2 days old, 2 weeks old, all the way up to in the school age as well. So Nikki is right here. She's our physical therapist. She works at our office, but as well as Novant, exit, week 23. We go by exits up off of 77, but she is also working in the NIC unit as the PT, so she's really doing a good job educating the nurses. Lots of times when they walk up, they will often look to the right, so Nikki's trying to really educate the nurses to help rotate that head to the left, and she's gonna go more detail with that, because just how upon the nurse, so certainly she's trying to do in that setting with helping to educate, as well as certainly Amy is here as well. She worked and is on the cleft palate team here also in Charlotte and worked at Pitt on their craniofacial team. So we're glad we're gonna hear her speak in a few minutes about speech. Yes, we live up in the Lake Norman area. There's, easy access to transportation, even though 77 can sometimes be a parking lot. Certainly, and the fine dining and great restaurants that are in Cornelius, Davidson, as well as Mooresville. The objectives today is we're certainly going to try to help show you guys how we can identify the role of PT. I think sometimes people think PT, how does that go with oral development? But Nikki's going to show you certainly what we're looking at to identify the impact of a lip and tongue tie with feeding and swallow. Certainly also the airway's contribution to speech production and deficits that result from unregulated or compromised systems. Dr. Summer did a great job earlier going over that and even had amazing models. So we will modify so we won't be redundant there too. So certainly, burnout's real with therapy world right now. And so certainly we all think about alone, we can do so little, but together we can do so much. And that's by Helen Keller. So I agree, the collaborative effort, I was up at Temple University, Albert Einstein Hospital, working on a trach and vent team. And so I had the opportunity to collaborate at that point with amazing PTs and OTs. So it is really nice at our practice that we're all under one roof right now. So lots of times we get referrals, and this is where the referral will come in. This is speech therapy. And a lot of times the parents are like, I had speech therapy when I was in school, so that's how they relate to us. But really what we'll do is bring them in, okay, so they're starting to have some feeding difficulty. So we start to look at all these different, like the reflexes, how they're integrating. Nikki's looking at the postural security. We're looking at the motor planning with feeding. So lots of times we need to go right back down here to the central or peripheral nervous system and work our way up. So that is what we're all trying to do in the clinic, is work on these systems to help improve the development and the intellect at the top. So I'm going to let Nikki hand it over to you.
Hello. Is this on? Yeah, it is. I'm Nikki. I'm the physical therapist at Speak to Me, and I'm sure most of you are kind of surprised that a physical therapist is here today. But I work very closely with Leslie and Amy with mostly our babies that come into the clinic, and many of them come first for feeding issues or cleft and lip palate or tongue and lip tie. And hopefully today you can realize how much of an impact I can help, or a physical therapist could help as part of your team. So For physical therapy in general, you all probably think of having a knee surgery, breaking a bone, and rehab. In pediatrics, it's very different. My job is to habilitate these kids, not rehabilitate them. So we're teaching them to learn how to move, the correct way to move, and develop their muscles in the proper patterns. And these skills are very crucial for safe and efficient eating, swallowing, and that we can address any other underlying limitations that may be contributing. So you'll see, I'm going to start off with a case study here. This little baby here is a patient of ours, and she has an amazing NAM, but it posed a big problem for the family where I could help out. So this is baby J. She was born at 40 weeks gestation, no complications, has a bilateral cleft and lip palate. Her NAM was placed in August at around 1 month of age. She came to our office for feeding therapy and physical therapy. During my assessment, we noticed she did have a torticollis, so she had a preference to tip her head one way and turn another. She also had difficulty with suctioning and feeding. The parents were actually very concerned. This NAM, if you can see, kind of comes past her nose and sticks out. So how is this baby going to do tummy time and develop head and neck control when the minute she's so little, she puts her face on the ground, she's going to pop that thing right out. She can't really snuggle on the parent's shoulders either, because then it will pop out. While they can put it back in, it does pose a problem. So with my help, we were able to get her nice and strong, reposition. We used towel rolls, different wedges, and she is doing great, and she will have her surgery in December. She had that NAM in. It'll be about 13 weeks by the time she has her surgery. So without any intervention from PT, this child probably would not have full head and neck control. She probably would not be rolling, which she is almost doing, and she certainly wouldn't look like that on her tummy, all of which is important for her feeding and her motor development. So she had what we call torticollis. So these babies have a preference to tip their head one direction, turn another. So we do see it quite often with our cleft and lip palate babies, but we also see it quite a lot with our babies that have a tongue or lip tie. So it is very important that PT gets involved so that that fascia is nice and tight in their mouth. It doesn't just stay in their mouth. It goes all the way down their neck. It can go down their side. It can go into their spine. So what we do is we help these babies get nice and loose. We do some massage, craniosacral therapy, and we work a lot with positioning with their feeding to help them get them in the best position in order to allow them to feed well. And then if they have the release done, we can get them in the best position. Everything's loose, so that release can be more successful. So how can therapy help? This right here, the baby right down here, this is where she is now. So she doesn't need any more wedges. We help kids learn how to walk. You can see in the background, we have a lot of fun while we do it too. Maybe not always, they don't think so, but we try. So when I was in college, my professor for cardiopulmonary rehab always said, if you can't breathe, nothing else matters. And I do believe that when I sat there, I kind of rolled my eyes and thought, well, as a PT, if they're coming to me, they probably can already breathe pretty well. But I realize now, after all my experience, how important breathing is and how much of an impact we have. So the torticollis babies, a lot of times that torticollis with that tongue and lip tie is there because those babies are smart enough to know that they have to position their head that way in order to breathe, because otherwise their tongue is starting to block some of their airway. But PT gives children the tools they need to help strengthen the muscles so they can have proper breathing techniques. It can help with sound production. It can help with give them a solid foundation so that they're using all those postural muscles and we're strengthening them in order to allow them to breathe better. We see a lot of them with cleft and lip palate. Sometimes we get older kids that have not had much intervention, or it's been much later on. So if I can give them a lot of good strength in their abdominal muscles, give them better postural control, then they can start to learn better where to put the air out to make better sounds. Pierre-Robin sequence, some of them, if it's severe enough, they need to have a trach. We've seen some of those kids along the way. We can use a lot of therapeutic taping, a lot of strengthening to help give them a good core so they can use the right muscles to help breathe to hopefully wean off that trach. And then our tongue and lip ties often have very poor postural control, rounded shoulders. If they're older, really working on releasing all that fascia and tension. So how can PT help? It is very key for children with craniofacial and feeding disorders. We can help with postural improvements in breath control, head and trunk control, muscle strength, overall body positioning, and then also look to see if there's any underlying things that maybe nobody has noticed that may help them. What we do is I work a lot on tummy time, head and neck strength, a lot of core strengthening, proprioception activities. Some of these kiddos don't really have good body awareness. They don't really have good muscle control, so we help with all of that. I do a lot of positioning during feeding and obviously help facilitate those motor milestones along the way through that. So like this baby right here actually has a really bad torticollis, scoliosis, and many other complications. And so Amy and I worked really hard to get him in a very good position in order to allow him to do some feeding. So hopefully you can understand that collaboration is very, very key between all disciplines. I think that's kind of been a theme of this conference. But we as PTs can really help, particularly with early intervention. The earlier, the better, the milder, the easier. Most kids don't outgrow a lot of their issues when it comes to PT things, which many doctors like to tell parents, which is kind of our little pet peeve. But we can significantly improve the outcomes for these kids with these feeding difficulties and really help you guys and speech therapists.
Thank you. Great job. So as she was saying, the interventions that we deliver, a lot of our families love that we're under one roof. So we have families drive an hour to get to our office one way. We've even had families come up from the beach and get a hotel and spend the night. So it's really neat things that we're doing up at our office. So certainly part of this is establishing rapport with the family. They come in, like you remember the one time when the family had to pull over on the side of the road. The mom came in so dysregulated. You know, we have tea there for them just to help them because they're so nervous what's going on with the feeding. So certainly Summer talked about this earlier as far as the muscle groups, but I just wanted to point out that certainly feeding is more complex than walking and talking. And that's what Dr. Summer said earlier as well. There are 7 muscles that are directly related to the tongue. So what are we looking at? We're looking at jaw stability, lip closure. We're certainly also looking at tongue protrusion, lateralization. Some of the kids that'll come in the clinic, they'll put their jaw on the table to get jaw stability. And so they're needing that input into the jaw. Also as well, talking about, in order to advance to solid feeding, they're gonna have to be able to have jaw closure and they're gonna have to have lip closure. So if they don't have those 2 skills, you can imagine how that's gonna disrupt with the feeding development piece. So we have a little baby here. Just wanted to see. So this is one of Dr. Capitan's patients. It's not showing up in real time. Well, you can hear the baby. So what we're looking for is we're doing whatever we can do to help this bond or interaction with the mom. So we're looking at positioning. So lots of times we will get PT to stop by. We'll figure out, okay, how do we get this baby to be able to become a more efficient feeder? So certainly too, you watch the cues. We help educate the moms on when it's going to be able to feed the baby. Let's see if I can go out now. And see if we can go. Might have touched it like Dr. I'm going to keep going on. Certainly newborns, we are also looking at the drooling, the tongue deviating to the right, the blanching, short frenulum, difficulty latching. So these are all symptoms that we're certainly looking for. Did you get it? Thank you. I don't know if that'll, there we go. So you can see we're looking at what is the tongue doing. This particular baby had a difficult time, obviously, latching. We were trying to figure out different positions, obviously different bottles, different nipples to help with the mom feeding. I think this was the particular case where the hospital didn't have any bottles or anything ready, so that's why Dr. Capitan, now his team, are going out and getting baskets and bottles and things like that to help the moms be prepared. So certainly too, just looking through the symptoms with tongue tie, we did see a baby on Monday, it was clicking. And so having a difficult time with the tongue to palate suction. So in that lingual grooving to help with the management of the milk. And so just simply by us changing the position did help, but we're gonna monitor it. And certainly we look at the function, and we see this often with the baby's projectile vomiting, and most of all too, these collapsing bottles. They have a baby right now they're working with that they have the Haberman feeder, which is a specialty cleft affected bottle. And the feeder, she's chewed or collapsed two of the nipples, 3 of the nipples, and they're very expensive. So certainly have contacted Dr. Capitan's nurse, Lauren, to be able to help communicate that to the team. So of course too, we have another baby you can just see with the fatigue. I'm gonna see if I can pull the video again, if this will work. This is an example of the fatigue that we see. So we get the mom, it's showing on here, but we help figure out how to get the jaw stability. Using the finger will help to support the cheeks. And you can see the baby is a little bit in fight or flight. She does have her hands up. There you go. Okay. So we give strategies or interventions to the mom to be able, that's okay. Thank you. But you can see the mom is holding the bottle and then helping follow the baby's lead to be able to help. Let's see if I can get it back here. I'll try not to do the videos. I might need your help one more time. So quickly, the midline deficits, lots of times the parents, they will have a sacral dimple. They might obviously have cleft and lip palate. I do have one more video I was going to show later on. Okay.
Is it not clicking?
Let me do anything.
Not the clicker.
Clicker. Okay.
It's not changing on there.
Yeah. Sorry. I'm keeping an eye on the time. Let's see.
It's changing. All right, try it.
So I slowed it down so you could see in real time how the baby is, sometimes we see a little bit of combative, helping to get the latch reestablished. This was out without any interventions, just to see how the baby was feeding. So mom was helping to stimulate to be able to see if the latch would attach. I'm happy to report we've been working with her. She's 3 years old, and mom says she's eating everything. And her speech is delayed, but we're certainly going to work on that language development. The conquering the midline deficit, certainly Nikki spoke earlier about torticollis. Obviously, we had some great earlier talks about sleep apnea and sleeping. I have seen a child in the past that had behaviors were presented, so they came to our office the raccoon eyes, and so we had conversation with the pediatrician. They were willing to do a sleep study, but they were getting ready to give her psychotropic medications, so help with the behaviors, but really it was because of the sleeping patterns. So that's certainly important, why sleeping is certainly important. About 4 months of development, it's certainly important with mouthing, this discriminative mouthing. So a lot of our parents come in, they've never mouthed, put the remote in their mouth, the keys. So, you know, if you guys are seeing the siblings or the little ones, really do encourage that discriminative mouthing. That should take place, which is gonna help with solid feeding. Really quick, this will be the last point. We did see a patient in Dr. Capitan's office recently. So Kimberly is here, and these are her gloved fingers here. She pulled back on the upper lip. This little guy's 12 months old, born with cleft lip and palate, but certainly he is having a difficult time with solid feeding. So as you can imagine, eating chicken nuggets, mashed or like French fries and all that. They really like McDonald's, because basically McDonald's is minced up chicken meat shoved back into a shell. So all they really have to do is smash it on their palate. Going back really quick too, you can see right here, like I think Dr. Closey was talking earlier about blanching. So we certainly that night spoke with the team about what we saw. Once again, we can't diagnose appearance according to our American Association of Speech Language Pathology, but what we can comment on is function. So I know you spoke earlier about pacifiers. There was a little kid that came in the office the other day, and he's three years, and he's got the thumb, and my office person was like, he's so cute. And that's one of the goals we're trying to decrease are the oral habits. So we certainly do encourage the parents, if they start to see the thumb, use a teeter, something like that to get that thumb out, just to help, because at about 8 months old, we hope they go from sucking to chewing, which leads me on to the point of the observational observations we're certainly doing. You can see in this picture that the moms will feed them and take the spoon to go up, but we're trying to get them to learn to pull it out, because we want them to learn how to activate the upper lip muscle, which is going to help with the lip competence. Today, while you guys were chewing, there was a lot of things taking place. The posterior cheek activation, rhythmic jaw movement, and with pressure and consistent and complete tongue lateralization. And that's what creates the rotary chew. So can you guys imagine why a lot of kids, not because their parents are vegetarian, cannot chew meat? So that's why lots of times they end up, or we see this a lot, the pocketing, and being able to poo. I think you guys pulled out some piece of egg the other morning with mango. So this patient came to my office Monday. These are the pictures that were sent to us. You can see here, I'm going to show a little video, and I hope that won't mess it up. We'll try. This is my last video. So what we do is lots of times we will bring the patient in, and we'll ask them to bring food, and that way we can see the oral motor components, what's happening with chewing, with swallow. And then Amy was in there with me and did a Goldman-Fristow test of articulation, which is, if you can wait just a second, I'll have you flip it back.
See if it'll come up
Click it.
there. Yeah, see.
So I'm going to just give you, I slowed it down for you guys to be able to see, but Amy did the Goldman-Fristow test of articulation. So lots of times we take the functional outcomes and give it to our providers that we work with and give them the information how it's impacting function. So what we'll do is see a lot of compensations with her head and neck. it's taking her a very long time to chew and eat, as well as certainly she eats candy. Her mom brought a lot of candy. Mom did give us permission to be able to show you this, but I slowed it down so you can see all the compensations, which I understand we compensate. However, you can see she swallowed it whole, and she's 7. So her mom talks about she has difficulty, constipation, things like that. So we also found out too, just here's the Mayo assessment that we did do, and you can certainly see the lip competence. And just look right here with her compensations. To open her mouth, she was at 52 mm's, but she was having to help gravity help get the tongue off the floor, and then also 215 without. So she could minimally open her mouth without. Her mom helped her to hold her head in neutral position, because when we talk or eat, we're on the neutral position. We don't eat with our head up. So you can imagine that her tongue is certainly is restricted. The provider, I've not worked with him, but he is asking me to have this fixed in 2 weeks. And I'm like, well, she's been swallowing and feeding like this since she was in utero. So this has been 7.5 years. So I certainly am not going to be able, so we're helped with the timeline, what we're going to plan to do, but she has 26 sound errors, which means she's 7 years old almost, and she's talking like a 3-year-old, 11 months. She's sitting in the school system. She's in a dual immersion program, hates it, hates school, because you can imagine all these errors that she has. It's impacting her abilities in school. We've all seen the textbook pictures. I just wanted to point out here, when we say the sound like S, your lateral edges of your tongue should be in the palate. So why do we get the frontals? Is because the tongue won't fit into the palate. So that is what we're trying to do, is get the tongue up into the palate to help with these speech sounds. And function is what we're helping on. I'm going to pass it over really quick to speech so she can discuss about airway.
Sorry. Hi, my name's Amy, and I trip up the stairs occasionally in the afternoon after I've had too much coffee. So I just wanted to talk to you. I can't compete with Dr. Summer. There's no way possible. I was going to talk about speech, but I'm going to talk to you about what I love to talk about, which is cleft palate and VP function. I originally started at the University of Pittsburgh, Cleft Palate Craniofacial Center, and I trained on a full-time cleft palate team for 10 years. It changed how I participated on the team. It changed everything about my life, looking at these children as people who have complicated systems that interact with each other. And I thought, holy cow, what's my job? What do I have to offer? Well, I learned really quickly, and I learned a lot. I wanted to share about airway and how a speech pathologist can participate in airway and speech during these cleft palate teams. So I went to my mentor because I had my book. I was very green, and I had my file, and I went and I thought, oh no, this child has Treacher Collins. I don't know what that one is. And so I took it to her and said, nope, can't take that one. I don't know what that one is. And she said, oh, you're taking that one. Okay. I said, I don't know what to do. She said, how old is the child? I said, Mikey's 6. Well, what do you expect of a 6-year-old? Well, and so I blurted out my, everything that I had to say. And she said, so get him there. Okay, I'll do that. So obviously with Treacher Collins, we have a lot of airway problems. We have a lot of anatomical problems. We have a lot of palate problems. We just have problems. But we also had Mikey, who was the most amazing child I have ever met, and I will never forget him. And I went in there and I started working backwards. Here he is. What do I need to do to help this child live the fullest life possible? And that included looking at his dental occlusion, looking at his general health, looking at his social situation, which was quite complicated. Also looking at VP function. When is he getting his trach out? Does he go to school? All of these things. And it just changed how I am a practitioner and how I practice to this day. So very quickly, the job of a speech-language pathologist on a cleft palate team is stressful and wonderful. My job is to figure out very quickly, what is a regular kid type thing? Oh, you say this sound incorrectly. Oh, you have a phonological processing problem. Oh, you have this. Oh, but you also have VPI, velopharyngeal insufficiency. Now I have to figure out, is it because your palate's too short? Is it because there's a lack of tissue? Do your lateral pharyngeal walls not move? Where are your adenoids? And so there's a constellation of things that I have to peel through and that we all have to peel through and prioritize and figure out what's going to work for this young child. I also had the privilege of doing, in Pittsburgh, I got to study under Betty Jane McWilliams, and that was like everything to me at the time, and she preferred video fluoroscopy. And I got to work in the Children's Hospital, and I positioned, we did how, I don't know, but get the barium up their nose of a 3-year-old to snort down and then get in position and talk. That's a trick. But it did help me as a parent later on, that's for sure, when the medicine came. So it was a wonderful, wonderful ride. And what I also learned is that you have to be an advocate. My job was to be an advocate because all of these other things are well planned out. We have to have this amount of growth before we can do this. We have to have this before we do that. Makes perfect sense to me, but this child can't function. Can you do it sooner? No. Please. No, prove it. So I have to go backwards and prove it. This isn't a kid type thing. His palate is too short. He's been in therapy. He's got fantastic parents. Now he's stuttering because he's so frustrated and he can't function in school. So the job of the speech pathologist was also to be an advocate for that whole child. Thank you. I know you've been waiting for a long time. Also, I wanted to point out that we have pads in your little bags for referrals. I love talking about cleft palate, and this is my plea for Speech Science Lab. Anybody who just wants to donate one, I will put that together for you like you wouldn't believe. I've worked with Dave Zajac, and there are actual ways of measuring the residual closure space for pre and post-op so that we could get some really good numbers. So thank you very much.